Good afternoon, everybody. As you know, viscosupplementation by intraarticular injection of hyaluronic acid is a worldwide used symptomatic treatment for osteoarthritis of the knee, but also of the hip and other joints for over a quarter century. However, as Ravindra said, despite positive assessment by clinicians, a high level of evidence, some guidelines remain failing to recommend it. And recently, the long-standing classification of viscosupplements as medical devices is called into question since the FDA decided to reclassify HA as a drug and no more as a medical device because HA has pharmacological effects and potential chondroprotective properties. To provide clarification to prescribers and users of Visco, a task force of European experts on osteoarthritis has been brought together in order to propose a consensual approach on Visco in knee and other joint OA, and the name of this working group, this task force, is European Viscosupplementation Consensus Group, EUROVISCO. EUROVISCO is constituted of 11 members from 7 countries, rheumatologists, orthopedic surgeons, specialists in rehabilitation, and coming from university hospital or public hospital, or some have also private practice. The working group has published 4 papers, the first one in 2015 in seminars in arthritis and rheumatism, and the 3 other publications have been published in Cartilage, the official journal of ICRS. So let's talk about the first paper. The method of the group is Delphi method after an exhaustive review of literature. On your screen, you have all these recommendations, but I just want to focus on the statements and recommendations that have obtained an unanimous agreement by obviously all the members of the task force. The first one is Visco is an effective treatment for mild to moderate OA. I think everybody is okay with that. Viscosupplementation is not a good alternative to surgery in severe hip osteoarthritis. Viscosupplementation is well tolerated, as it has been shown in the treatment of knee and other joint OA. Visco should not be used only in patients who have failed to respond adequately to analgesic and NSAIDs, and some patients would like to be treated with Visco for not taking drugs, oral drugs. Visco is, that is very important, a positive indication. It's not a lack of anything better. I don't know what to do, so I try viscosupplementation. Another very important point to underline is that the dosing regimen must be supported by evidence-based medicine, so randomized controlled trials. Cross-linking is a proven means for prolonging IA, intraarticular resistance time of HA. The 8 is the best approach to inject knee joint is a lateral mid-patellar one. And the last one is when viscosupplementation is performed under fluoroscopy, the amount of radio-opaque contrast agent must be as low as possible to avoid diluting viscosupplement. As you can see, the first paper was a very general paper on use on viscosupplementation. The second one was focused on retreatment, because also systematic reviews of its repeat use showed favorable benefit-risk ratio of retreatment of viscosupplementation. No study was specifically focused on the indication of retreatment. So the methodology of the work was the same with the Delphi method, but the first step was to determine what is success and what is failure of viscosupplementation. The second step was to determine when and how to retreat patients in whom first viscosupplementation failed. And the third step was to determine when to retreat patients who were previously successfully treated with viscosupplementation. And the definition of treatment failure that has been accepted by the group was remaining pain after injection over the threshold of the patient acceptable symptom state and the patient dissatisfaction, both high level of pain over than that of PASS and patient dissatisfaction with treatment. For example, you can see here the decision tree. Patient come back and tell you lack of efficacy of the treatment that have been performed 6 months before. The first question to have answers is, was the indication correct? If not, obviously no retreatment. If there is no evidence of OA, if there is a flare-up of the disease, if pain is due to another cause than osteoarthritis, meniscal tear, tibial plateau fracture, tendonitis, osteonecrosis, and so on. If yes, the second question is there predictive factor of failure, such as severe obesity, severe joint space narrowing, or very high level of pain? If yes, the recommendation is to discuss with the patient for other treatment modalities. And if patient decide to be retreated, we can retreat it, but we have to explain him that the chance of success are very low in this kind of situation. There is no predictive factor of failure. The next step was the previous protocol correct in terms of number of injection, in terms of volume to injected, in terms of interval between injection in case of repeat injection? And was the injection really intra-articular? Are we sure that the patient has been correctly injected? If yes, no retreatment, obviously. We don't have any reason to retreat patient. But if the protocol was not correct, it is possible that the injection has been made not intra-articularly, so we can retreat the patient with an adequate protocol and with an imaging guidance to be sure to inject intra-articularly. The other algorithm is what to do with the retreatment in case of previous successful viscosupplementation. Patient comes at month 6 and is always symptom-free, so no retreatment is recommended. If the patient is little symptomatic, the question is, if the patient is very young, in case of early osteoarthritis with high risk of progression, in sportsmen with high level of activity, sport activity, in patients with severe comorbidities that contraindicated, for example, NSAIDs and other drugs, in patients with contraindication to total knee replacement, we can retreat patient even if low symptomatic. At month 12, 1 year after injection, if there is increase of pain between month 6 and month 12, it is recommended to retreat patient. But in patients where we remain still symptom-free at month 12, no retreatment, but we can propose retreatment in patients with high risk of progression, with in professional sportsmen and in young patients with high risk of progression, because it has been strongly suggested that HA has chondroprotective effect and can slow down the progression of the disease in such patients. In patients who remain little symptomatic at month 12, we can propose not to retreat the patient, but if there is no increase of pain between month 6 and month 12, if patient doesn't wish to be retreated, if there is no risk factors of progression, and if pain remains under the threshold of PAS. So you can see we have published 2 sets of recommendations that can help practitioners in their decision making. And the third and last publication I would like to talk about is the recommendation for optimizing the chance of success of viscosupplementation in knee and hip osteoarthritis. So this work had 3 main goals. The first one, to identify the population subgroups that can benefit the most from viscosupplementation. The second one is to provide recommendations on techniques of injection that will optimize the chances of success. And the third is to discuss the appropriateness of using HA in several clinical situations that are commonplace in daily practice, but have not been yet the subject of specific studies. It was the same methodology with literature review and Delphi method for the voting session. And the expert achieved unanimous agreement in favor of the following statements. The first one is a good indication based on both an accurate analysis of signs, symptoms, and clinical history, and a careful clinical examination may improve the chances of success of viscosupplementation. Second one, a good indication based on a precise analysis of the radiological features may also improve the chance of success of viscosupplementation. A good technique of injection and the use of imaging guidance may enhance the chances of success of viscosupplementation. And the fourth statement is radiological severity. For example, Kellgren score 4 versus 1 to 3 may also influence the response of viscosupplementation, both in knee and hip osteoarthritis. There was also 3 recommendations on the injection techniques. We recommend administering viscosupplementation in the knee through a lateral patellofemoral route. We recommend performing visco under fluoroscopy or ultrasound guidance in the hip. And we recommend performing visco under fluoroscopy or ultrasound guidance in the ankle. Other recommendation, we obtain unanimous agreement. We recommend withdrawing any synovial fluid by careful aspiration before injecting HA into the joint. And we recommend respecting the dosing regimen, the number of injections, the interval between injection that has been proved by controlled randomized trials, regardless the joints to be treated. And sometimes when viscosupplementation is performed in a small joint of middle-sized joints, the injector opts for a single injection with a linear viscosupplement that has been proved to be effective in the 3-injection regimen, and we recommend to use only the protocols that have been proved by randomized controlled trials. And what are the appropriate patients to be treated? Patients with symptomatic mild to moderate knee osteoarthritis with normal weight or moderate overweight, not sufficiently improved by non-pharmacological intervention and analgesic NSAID, That is the classical recommendation. But also patients with symptomatic mild to moderate knee OA with normal weight and moderate overweight with contraindication to NSAIDs and analgesics, and patients with symptomatic mild to moderate hip osteoarthritis not sufficiently improved by non-pharmacological intervention and NSAIDs. But we have to keep in mind that each patient presents with individual needs, and individualized multimodal approach is strongly recommended, with viscosupplementation in the heart of the decision. If the patient wishes, for example, to postpone arthroplasty or expresses his preference for high A rather oral or surgical treatments, viscosupplementation can be performed provided the patient has been well informed of the benefit-risk ratio of the procedure. So I hope I have well explained to you that the EUROVISCO guidelines is a great resource in the daily management of patients in real life situation. And I show you the group. One is missing, and I think everybody is here on this slide. And if you want to participate to an international study on retreatment, the condition of retreatment with viscosupplementation, you can just at the exit, you have a desk with 2 computers, and I think many among you have previously answered this questionnaire, and you can do it again. Thank you.